siga escuchando tu voz entre las olas, entre la espuma. Mientras tenga que cambiar la radio de estación, porque cada canción me hable de ti, de ti, de ti. Mientras siga viendo tu cara en la cara de la luna, mientras siga escuchando tu voz entre las olas, entre la espuma. Mientras tenga que cambiar la radio de estación, porque cada canción me hable de ti, de ti, de ti.
Right now, all we wish for is to be able to meet once more. But until that moment comes, our birds are taking a break. They've taken to the skies, flying over our mountains, wetlands, forests and cities, waving at us from the distance. They're coloring the treetops and everything above to remind us that there are over 1,920 species to admire. And they're preparing for that moment when you'll be able to come back in awe to the country that is home to nearly 20% of the world's bird biodiversity, as well as more than 80 endemic species, and that has led the global Big Day competition for 4 years in a row, registering 1,574 species sightings in 2019 alone, and achieving the first place once more in 2020's virtual edition. We'll meet again soon to keep on enjoying together the diversity of our bird species, in renewed destinations with sustainable and biosafe experiences that guarantee your well-being.
Now is the time to take care of yourself, to take care of those dear to you, to take care of everyone else. Stay at home. Read that book, binge that series, or finish that project you started. Soon we will meet again. Soon our rhythm will move you the way it always has, and you'll see our landscapes like never before. Soon we'll welcome you once more. Let's take care now so we can meet again soon.
Today, all we wish for is to meet once more. Just like pauses in music are a key part of the melody. The rhythm of Colombia and our destinations are taking a break, so that you may find them renewed, confident that they've taken the best of care and that you'll enjoy them like never before. Because the one thing you can definitely count on is that you'll meet once more with our unshakable rhythm, with our joyful warmth. We'll meet again soon.
Good evening and welcome to the first Acome and LAUGHH Foundation Academy updates. My name is Juan Pablo Maldonado. I'm the director of this event. I'm a medical student from Colombia. I've been part of the LAUGHH Foundation Medical Mission for 4 years now. I'm a member of Acome and I will be joining you as your host tonight. To begin, I want to mention our patrons that are making this incredible event possible. GEO Asesores, AMSA, American Medical Students Association, Intermetro in Puerto Rico, Congreso Expedientes Médicos, Students Network Organization, Elsevier, Editorial Panamericana, Kaplan Medical, Cardio EKG, Grupo CTO, FELSUSEM, and Johns Hopkins University. Thank you so much for supporting the globalization of medicine in Colombia, Latin America, and all around the world. We would like to remind you the steps to obtain certification. You must be registered, and at the end of every day, our team will enable the attendance form that it's going to be open for an hour, and it includes a keyword that will be displayed on the screen during the conferences. And finally, you must have attended at least 7 of the 9 days to get your certificate, and that's it. Remember, this is the 8th day of conferences. This week, we will talk about nutrition, and We will talk about ophthalmology, so please welcome first Juliana Camargo and Joaquín Marrón. They are going to do the conference titled The Obesity Pandemic, Exploring the Obesity in Latin America and Latino Immigrants in the US. Juliana Camargo is a postdoctoral fellow at the University of Kansas Medical Center, where she develops research in the main areas of nutrition, cancer, and diabetes. She received her bachelor in nutrition science from Pontifical Catholic University of Campinas, Brazil. After graduation, she worked as a clinical dietitian for 4 years and pursued her master in public health from State University of Campinas in Brazil. In 2015, Juliana moved to the US to pursue her doctorate in medical nutrition at the University of Kansas. She focused her research on nutrition among Latino populations in the Kansas City area and also developed projects in global health and nutrition in Brazil, Colombia, and Peru. Since 2017, she has served as nutrition advisor at LAUGHH Foundation, where she supports the development of personalized nutrition education materials, nutrition counseling, and mentored medical students on nutrition education. Juliana likes to travel, try different food, and spend time with her dog, Nalu. Her favorite quote is from Dr. Martin Luther King Jr., who said, "I have the audacity to believe that people everywhere can have 3 meals a day for their bodies, education, and culture for their minds, and dignity, equality, and freedom for their spirit." We also have Joaquín Marrón. He has a nutrition degree from the Universidad del Valle de México, Campus Cuernavaca, between 2009 and 2013. He is a Master of Science in Nutrition from the School of Public Health of Mexico between 2015 and 2017. He currently works in the project Collection and Evaluation of Nutritional Information, Front of Pack Labels, Marketing Present, and Hold Claims through mobile app in Mexican population, with the director of Dr. Lilia Pedraza at the Center for Research in Nutrition and Health of the Public Health National Institute of Mexico. His research focused on the study of the consumption and purchase of ultra-processed foods in Mexico. So welcome to this conference.
Thank you very much, Acome LAUGHH, for inviting us to do this presentation today. I'm very happy to be here and share some of the research and knowledge that we learned. I will be presenting together with Joaquín, but before I start, I want to introduce and mention why we are doing this presentation together. So I had the opportunity to see the work from Joaquín 2 years ago in the conference from Latin American Nutrition's land in Guadalajara, Mexico. And it was very interesting and enlightening to see a new way to approach dietary intake and how people consume foods and divide foods. This is a methodology that was developed by Latin American researchers. So that's why I invited Joaquín to present with me today. After his presentation, I'm going to share a little bit of my work with Latino immigrants here in Kansas City. So now I'll give the word to Joaquín.
Juliana. So to begin, the presentation is called The Obesity Pandemic, Women at Risk. Given the evidence collected by nutrition and health researchers in the last years, nowadays we know that obesity is not just the result of how much population consume foods or how much they do exercise, but rather it's a complex system in which different and dynamic determinants interact with each other to create this disease. Such determinants are biology, individual activity, individual psychology, social influences, food production, food consumption, and activity environment. Given the presence and interaction of these determinants, it's worth mentioning that one health or strategy policy alone won't help in reduce the obesity epidemic in the world, but rather is necessary to create and develop other strategies that focus on control each one of these determinants. In this context, policy determinants such as food industry, trade investment, marketing, school health policies, physical determinants such as region, urbanization, food retail outlets, economic determinants such as food cost, socioeconomic status, and sociocultural determinants such as education, women work outside home, and food preparation influence and determine the dietary habits of the population in two ways. The first one, these determinants can be responsible to a large size portion of consumption of energy-dense foods and sugar-sweetened beverage, which in consequence will lead them to have a high weight that which traduces as obesity and other related chronic diseases such as diabetes, cardiovascular disease, and cancer. However, these same determinants can also be responsible to lead the population to eat adequate sized portion of nutrient-dense foods and also adequate consumption of water, which leads them not only to preserve their nutritional health status, but also will help them to prevent the development of these chronic or other chronic nutrition-related diseases. However, in the last years, ultra-processed foods have become part of the dietary partners of the population. But what exactly are these products? According to Monteiro and other researchers, ultra-processed foods are industrial formulations made basically from substances derived from foods, such as oils, fats, sugar, substances synthesized from other organic sources, such as interesterified oils, maltodextrin, inverse sugar, and preservatives and additives, such as humectants, emulsifiers, colorings, and flavorings. The different quantities and combination of these ingredients can create different types of ultra-processed foods, such as cookies, pastries, sweet bread, salty snacks, ready-to-eat foods, sugar-sweetened beverages like soda, industrial fruit juices, among others. Given its increased production and distribution, in the last years, the ultra-processed food sales has increased in Latin American countries. For example, an increased rate in sale of approximately 550 to 700 calories of ultra-processed foods has placed Chile as the first retailer of these products, followed by Mexico with approximately a sales of 520 to 550 calories, whereas in Colombia, an increased sales of 210 to 250 has placed Colombia as the sixth retailer of these products. Given these increased sales, there are different segments of the population that are at risk of consuming these products. For example, in the United States, is the first consumer of these ultra-processed foods. And other Latin American countries are just having the half of this consumption. In this graphic, we can clearly see that socioeconomic status is an important determinant of the consumption of these products. For example, in the United States, those individuals who had a high socioeconomic status consume less ultra-processed foods than those who have a low socioeconomic status. However, this kind of behavior is different in other Latin American countries. For example, we can see that in Chile, Mexico, Brazil, and Colombia, those individuals who have a high socioeconomic status consume more ultra-processed foods. Similarly, in residence area, by analyzing this consumption, we can observe that urban areas have more access of ultra-processed foods and therefore a higher consumption than those individuals who live in rural areas. Nevertheless, those individuals who live in rural areas have a high consumption, particularly those who live in Chile and Mexico, and different from those who live in Brazil and Colombia. By analyzing or stratifying the consumption of these products by educational level, we can see that in the United States, the consumption of this product is higher in those who have a middle educational level compared to those who have a low educational level. However, this kind of behavior is different in Latin American countries. For example, we can see that in Chile, Mexico, Brazil, and Colombia, those individuals who had a high educational level have the highest consumption of ultra-processed foods compared to the individuals who have a low educational level. When we analyze the consumption of these products in women, we can observe that in Latin American countries, the dietary patterns of these individuals is preserved because the consumption of ultra-processed foods is low compared to those women who live in the United States. Therefore, it's important to limit the consumption of these products in the further years to avoid to reach and lose the traditional dietary patterns of each country. But what exactly this consumption reflects in the population? In this graphic, we can observe that when the consumption of ultra-processed foods increase in the diet, the sugar intakes also increase. Clearly, in these tendencies, we can observe that in Colombia, Mexico, and United States, the consumption of these products increase the consumption of sugar. Furthermore, by taking a closer look, we can observe that the low consumption of these products has the low sugar intake. For example, in Colombia, a consumption of nearly 0.4% of energy contribution of ultra-processed foods reflects an energy contribution of added sugar of 12.4%. Whereas in Mexico, a consumption of 4.5% reflects a consumption of added sugar of 70.7%. Whereas in the United States, an energy contribution of 30% of ultra-processed foods reflects an added sugar intake of 10.3%. Interestingly, we can see that in Colombia and the United States, even the lowest consumption of ultra-processed foods surpass the recommended intake levels of added sugar compared to Mexico, where the lowest consumption is under this recommended intake level. Similarly, in this graphic, we can see a positive relationship between the consumption of ultra-processed foods and saturated fats. Clearly, we can see that the lowest consumption of ultra-processed foods reflects the lowest consumption of saturated fats, and interestingly, in Colombia, even the highest consumption of these products is under the recommended intake level of saturated fats compared to Mexico, and United States. So it's kind of interesting that this kind of behavior is because dietary partners of each population also has an important role in playing the consumption of these products. So in order to create better food policies strategies, is not only to limit the intake of these ultra-processed foods, but also it's important to create strategies that foment promote the consumption or a varied consumption of unprocessed or minimally processed foods, not only to preserve the dietary patterns of the population, but also to reduce the intake of these critical nutrients in the diet. In the last years, in the case of Mexico, Mexican women's health the rates of obesity in women have increased from 37.5 to 40%, such as the other nutrition-related chronic diseases. For example, diabetes has increased from 9.7 to 11.4%. High cholesterol and triglycerides has increased from 40.1 to 21%, and arterial hypertension has increased from 80.5 to 20.9%. These rates of nutrition-related chronic diseases are interesting because in parallel, the consumption of ultra-processed foods also has increased and has shown a positive association between the consumption of these products and the health status of Mexican women. So given these evidences, in Mexico, there are creating efforts to develop new strategies to limit the consumption of these products, such as warning labels in food products, and also creating other kinds of strategies that promotes a healthy food environment for the population. So there is important to now take a closer look of how the consumption of these products can reflect and determine the health status of Mexican women in the further years. Bueno, hello?
Okay. So Joaquin presented some data on Mexico and ultra-processed food. Now I'm gonna change a little bit the focus, but then first I want to explain why we are focusing so much and talking about women and obesity. So this slide are some charts from the World Health Organization for 2016, which shows the prevalence of body mass index worldwide for adults over 18 years old. So you can see the lowest bars are related to normal weight, the middle is overweight, and the one on the top is obese. The orange bar are the rates for women, and the blue bar are the rates for men. So we can see that divided by gender, women are at a higher prevalence at world level of overweight and obesity, which shows a trend for a higher risk for women for this disease. Next slide, please. So this is the estimation of excessive weight. That is a combination of overweight and obese for the Americas. And here I'm highlighting United States, Mexico, Brazil, because it's my country, and Colombia. So we can see that for women at reproductive age in the US, about 77% of women are with excessive weight. In Mexico, it's about 73%. Colombia and Brazil are very close, where about 60% of women at reproductive age are with excessive weight. Next. So why we want to focus so much on excessive weight and obesity for women? Because it can have different impact on their health and also for the health of their children or their offspring. So some of the diseases that are related to obesity, what we call comorbidities, are, for example, diabetes. We have also data relating obesity to liver disease, cardiovascular disease. Specifically for women, it is associated with infertility, and also there's association of obesity with breast cancer, which puts women at a higher risk of chronic diseases. Next. So I want to present some data of a study that we conducted here in the United States, specifically in the states of Missouri, Kansas, and Ohio. It's called ADORE trial. This trial was conducted by one of my mentors, Dr. Carson, and it was a randomized phase 3 clinical trial, which the goal was to check if supplementing women during pregnancy with DHA, which is a type of omega-3 fatty acid that can be found on fish, for example, salmon and tuna. So we tested to see if supplementing them during pregnancy would lead them to decrease the number of preterm birth. And then next slide, please. So I'm going to continue to talk. So in the ADORE trial, it was a randomized phase 3 clinical trial, so it was an intervention. And we have several data that we collected. So we started to follow women beginning of their pregnancy between 12 to 16 gestational weeks. And then we followed them until they deliver their baby. So we had information about their medical records, about their socioeconomic history, diet, supplement, blood samples, growth data. So, for example, data on how much weight they gained during pregnancy, and also data about the baby, so the infant outcomes. That is for researchers. Phase 3 randomized clinical trials are a dream to us because we can collect a lot of data, do a statistical analysis. What I'm going to present today is for partial results of ADORE, so I will not present about preterm birth, but I will focus on obesity and the weight gain from a part of the population we saw. In this study, we follow about 1,100 women. And we recently finished our data collection. We had our last baby that was born. So next slide, please. So one thing that was unique about the ADORE trial here that we conducted in Kansas and Ohio is that we also were accommodated to include immigrants who had their first language Spanish. So this picture, you can see part of our team here, of our bilingual team, that without them would be impossible to accomplish this work with our immigrant population. So as some of you know, United States, it's the largest country who receives immigrants worldwide. And one of the largest immigrant population here in US is what we call Latinos. So specifically people from Latin America who prefer their language as Spanish. So we accommodated that to include those women as well in our trial. So next slide. So explaining a little bit more for those who are not from the US and do not understand some of the terminologies that we use here. So why I'm presenting and talking about Latinos. So the term Latino here in the United States, or Latinx, the new term, is used to categorize those people that are in Spanish that are Latinoamericanos, or in Portuguese that are Latinoamericano. So this population can be constituted from immigrants and also from people who had parents or grandparents that were immigrants from Latin America. And why it's interesting to observe some of the data for this population, because immigrants have an interesting fact that they go through a change. So they change the environment from where they're living because they immigrate. And this is specifically interesting when we want to analyze the impact of environment and diet, for example, on their health. Also, here in the United States, for the Latino population, we see one of the highest rates of childhood obesity, of diabetes, and also for gestational diabetes. So that's why we also wanted to include this population in our studies and in our trial. Next slide. So I'm going to present data from these immigrants about this population, Latino population. I did some analysis on their weight gain during pregnancy and also their diet quality. So here in this slide, I'm presenting the recommendation from the Institute of Medicine for weight gain during pregnancy. So it is recommended that during pregnancy, women gain weight to develop a proper development of the baby and their health as well. But women should not gain as much as they want. There is a recommendation for that about how much they should gain. So in this table, you can see the recommendation. Basically, what that means is that depending on how women start their pregnancy, so their body mass index, they have an amount that is recommended for them to gain during pregnancy. Basically, as heavier women start pregnancy, they should gain less weight. And then that rate is divided by two categories. So women, we have the total gestational weight gain, so how much they should gain during the entire pregnancy, and also the rate of weight gain, that is how much they should gain per week for pregnancy. So here we have an example. Women who start, for example, their pregnancy with a normal weight, they should gain a rate between 11.5 to 16 kilos during the entire pregnancy. While those women who start pregnancy obese, for example, they should gain a maximum of 5 to 9 kilos. So next slide. For diet assessment, we measured their diet during the entire pregnancy. And then after that, we calculated a score to see what was the quality of their diet during pregnancy. I didn't use the same system that Joaquin presented before. The system that I use is a system, one of the systems that we use here in the United States that is called the Healthy Eating Index. But what is the Healthy Eating Index? The Healthy Eating Index, it's an index we use to analyze how much the diet is according to the dietary recommendations here in the United States. So for those who have never seen before this score, have never used, basically what that means is that people can have a total score of 100. So if they have a diet that is 100, means that they are following all the dietary recommendations. If they have a score, for example, of 50, it means that they are not following all the recommendations, but probably half of it. So this score is divided into categories. So the first one is related to adequacy, and the second one is related to moderation. So in the adequacy portion, these are the foods that are recommended, and they are healthier and are related to healthy outcomes during the life. So what that means, they have a score that ranges from 5 to 10 for each food. So if a person, for example, reaches a score 5 for total fruits, it means that they are eating the maximum amount that is recommended, and that is very good. If they're not eating a lot of fruits, for example, they can have a score of 1 or 0. The second part is related to moderation, so foods that we should eat in moderation and eat less. This is an inverse score. So what that means is that if a person, for example, is eating a lot of added sugars, they will have a lower score here. They can have a score of 0, 1, or 2. If they're eating less added sugar that is within the recommendation, they will have a higher score, so they will have a 10. So just to have like idea of what we did for this study. So next. So these are some of the results that we found. I'm presenting data here only of the Latino population for the ADOR trial. That was about, for this analysis, we included about 100 women. So for the women that we saw, their average age was 30 years old. They were at their second pregnancy with a parity of 1.7. The majority of the women that we saw, they had a low education level and a low income level for United States. So about 50%, more than 50% of them had completed less than high school, and they have less than 100% of poverty level, which is a measure that we use to analyze income. Again, reminding that this is a Latino population. So for the women that we saw, 3 in 4 chose Spanish as their primary language to communicate with us. About 87% were immigrants, and they were from 11 different countries in Latin America. But 62% of them were Mexicans, so majority Mexican population. They were living in the US for more than 10 years, majority of them. But even though they were living in the US for more than 10 years, they had a low acculturation. And what that means, so acculturation is a measurement that we use to see how people are adapted to the new country on social and environmentally, so interaction with other people. So this means that most of the women that we saw, they were following more the social patterns of their country of origin, of their country that they immigrate. Next slide. So I mentioned that we measure women weight gain during pregnancy and also how they start their pregnancy. So for this population that we saw, majority of women started pregnancy already with excessive weight. So about 38% of the women that we saw, that is in the darker orange bar that we see, they started already pregnancy obese, and about 35% already started their pregnancy overweight. So the minority of women were with the recommended weight when they started pregnancy. So we have to keep in mind that the women that we saw here, they should not gain a lot of weight during pregnancy, okay? So next slide. So we also measure how much weight they gain during pregnancy. When we look in the pie chart, we can see for all women, without dividing by their BMI categories that they started pregnancy, about 44% achieve the adequate amount of weight that they should gain during pregnancy, and only 27% gain more than what is recommended. However, when we divided these women by how they started pregnancy, we can see that those who started with excessive weight, here in the bars, so those who are overweight and obese, for overweight women, about 41% were gaining more than recommended, and 29% of obese women were gaining more than recommended as well. And while for those women who started pregnancy normal weight or underweight, they were not exceeding the recommendation. So next slide. We also measured that by the rate of weight that they gain during pregnancy, so how much they gain per week. And then we had a different picture as well, because when we look for all women without dividing by their BMI, we can see that about 46% were exceeding the amount of weight that they were gaining per week. So they were gaining more than recommended and fast. Again, when we divided by their BMI category that we can see in the bars, we can observe that women that are overweight and women that are obese, again, about almost half of them for obese women and more than half of them for overweight women are gaining weight more than recommended and at a fast pace. Then for normal weight and underweight, we now see that some of women are exceeding the recommendation, but not at the same level for those women who started with excessive weight. Next slide. So we also did some analysis to see what was predicting the weight gain for the women during pregnancy. And then in this analysis, we included several variables like the quality of their diet, their knowledge of nutrition, their income, their age, and then what result is that for total weight gain during pregnancy, only their pre-pregnancy BMI and their diet quality remain as significant in the model, and that predict 13% of their weight gain during pregnancy. So if women, and that was an inverse correlation, so if women started pregnancy already with extra weight, they gain less. Even though they were exceeding the recommendation, they gain less when compared to those who were normal weight. And their diet also predicts. So what that means is that if women had a high diet quality, they gain less weight. And if they have a more poor diet quality, they gain more, which shows how important diet is during pregnancy and to support these women. When we look for the rate of gestational weight gain, only their BMI was predictor of the rate and predicted only 5%. So that clearly shows that it's already like a metabolic change that they have that is leading them to gain weight, more weight. However, there are other factors that are impacting them to gain more in a short period of time that we don't know because we didn't include in the model. So we need to do more research to learn that. So next slide, please. Here in the United States, every 5 years, we have the release of the dietary guidelines for the country. So what that means is that it's a group of researchers that includes dietitians, physicians, researchers, will develop what are the guidelines for the country. And that will impact, for example, in the food production, in the policies, and also in clinic. In the past years, the dietary guidelines were also towards healthy adults. And this is the first year that we included not only healthy adults, but we also have specifically recommendations for women at reproductive age and also women that are pregnant. This is something new for this year of 2020. This is the recommendation for pregnant women. There are 8 recommendations overall. I will mention the first 2. So not surprisingly, because of the high rate of excessive weight that we have among women and pregnant women here in the US, the very first recommendation it is for women to have start pregnancy with a healthy weight and also consume more what we call the nutrient-dense food. And what that means is that foods that they will provide nutrients and not only calories. For example, ultra-processed foods. So we should eat more those foods that are rich in nutrients, for example, fresh fruits and vegetables. The second recommendation is related to diet patterns. So what they are recommended is that women during pregnancy follow more a healthy diet pattern. And what that means is consume more vegetables, fruits, whole grains, legumes, and nuts, seafood and vegetable oils, for example, olive oil. And decrease the recommendation of added sugars that are not naturally found on food. So, for example, the sugars that we will find in ultra-processed food, refined grains, red and processed meat. So this is something brand new that was released less than 1 month ago, and we are very happy that now there is a specific recommendation for women during pregnancy. Next slide.
So, in conclusion, the sales of ultra-processed foods have increased in the last years. As consequence, these products coexist with unprocessed and minimal processed foods in Latin American diets. Given that the increased consumption of these products reflects high intakes of added sugar and saturated fats, certain sectors of the population, for example, women, are at risk of developing nutrition-related chronic diseases. Therefore, further health and nutrition policies should focus on limiting the consumption of these products, but also in promoting the consumption and variety of unprocessed and minimally processed foods.
Next.
Mm-hmm.
So for pregnant women, and here I'm going to give more clinical advice and recommendations. So clearly should have more focus on promoting a healthy diet and a healthy weight for women of reproductive age. So women and their physicians, gynecologists, and nutrition that have access to women and nurse should start to motivate them and support them to have a healthy weight and a healthy diet even before they get pregnant. Do not wait until they enter pregnancy. Also, during pregnancy, we should focus as health providers on providing education for these women on how to support them to have a healthy weight gain during pregnancy. One of the main focus, because of how much it predicted their total weight gain, should be in a healthy diet, promoting more fruits and vegetables, and then minimally processed food, non-ultra processed food, so avoid all the soda, the added sugar, and then Colombia adding all the panela in the juices that I saw, and also support women that already started pregnancy with excessive weight to support them to do not gain more. So we should not blame them, but we should support them so then they can have a healthy pregnancy, gain the right recommended amount, and then after pregnancy they can start to think if they want how to reduce their weight, because that can impact directly their health, their future health, and also the health of their children. Next. So we are opening now for questions, and then in this final slide we included some pictures of Kansas City, where I'm living right now, from my beloved São Paulo in Brazil, and from Mexico City, where Joaquin is right now. So if you have any questions, we are happy to entertain.
Well, thank you for your talk. While our team is selecting the questions, on behalf of Acome and the LAUGHH Foundation, we want to thank our participants. We have almost 1,500 people from all over the world, American countries such as Colombia, USA, Ecuador, Brazil, Venezuela, Bolivia, Guatemala, Mexico, and Cuba. But also people from Spain, Burundi, Ghana, Kazakhstan, Nepal, Nigeria, Egypt, Sudan, and India that are making an incredible effort with their local time. So now we are going to start with the questions. And I have here the first one. How difficult is to achieve the labeling of ultra-processed foods? Because I understand that it was recently achieved in Mexico, but in countries like Colombia, it has been very difficult to reach this. Who should intervene for this to be achieved?
Okay, thank you. Very interesting question. Yes, exactly. This strategy, if I remember correctly, it started to be developed in 2013 in Mexico. So various social organizations and along with the Mexican government play an important role to fight to the food industry to implement this strategy. So, given this, the National Institute of Public Health of Mexico, start to design different kinds of studies to prove the Mexican government that the old label for saying like that, it was not well understood by the Mexican population. So there was the need to create a better label like this one, the warning labels, in order to population understand better how which products they should eat or buy or bought in order to consume. So first, to implement this strategy, first the institute needs a lot of evidence to create to choose the better warning level, to choose the best food label that suits the understanding of the population, and then present it to the Mexican government and implement it in order to help the Mexican population to choose healthy dietary patterns.
Thank you. I think we have another question. Older people need a special diet as well?
Can you repeat the question, sorry?
Older people need a special diet as well?
Yes, Juliana, do you want me to respond, or would you like to respond to this question?
We can both respond. You can start and then I complement.
Okay. Well, the evidence says that every stage of the human life requires different quantities of nutrients in order to develop development, and also to have a better, how to say it, health status, to prevent chronic diseases and maintain its health. So yes, older people also needs a special kind, not a special, but needs to follow certain nutrition and food recommendations to maintain their health status.
Mm-hmm. Yeah, just complementing that. So as Joaquin said, it all depends on their health status. So if they have any type of chronic disease or other diseases, so if they're healthy or not, and also age has an impact. So for example, we know as we age, we have a muscle loss that is due to aging. We have also a bone density loss. So there are some micronutrients that we should be focusing as well as we age, such as calcium and vitamin D. But that will also depend if they have other diseases as well, because it can have an interaction. So in this case, we should always to see patients in a more interactive base. So having, for example, a physician and a dietitian in the team that will be the professional that will learn about these changes and which the changes in diet should be done. But yes, they should have not a special, but they have some requirements that change. For the dietary guidelines that I presented here in the United States, we don't have one specifically for old people. There are plans for that, but for that to happen, it's all based on research. So that's why it's so important to be analyzing the diet and doing research to understand what is going on with our populations.
Thank you. I think we have another question. So what did you do with the ones with diabetes and hypothyroidism? Did you exclude them from this study?
I imagine this is for the ADORE study.
Mm-hmm.
So for the ADORE study, no, we didn't exclude women that had diabetes or hypothyroidism. The only women that were excluded from this study was those women that they did not want to participate, or also, for example, if during pregnancy they lost their baby. So if they lost their baby, they had the option to continue in this study or to leave this study. But we did not exclude for any chronic diseases. The only thing that we did was, for this, I presented like overall women. We didn't divide them by previous chronic diseases. We have that information, but I didn't change for chronic diseases now. But it's something that we are working to analyze right now. I don't have the results yet, but maybe in the future I can present.
Great, thank you. Next question. Did you see a significant increase in the number of women with gestational diabetes?
Do you have data, Joaquin, on gestational diabetes?
No, well, the National Institute of Public Health of Mexico has data, but currently I don't work in that kind of databases, so I couldn't respond exactly to the question.
For the ADORE study, we have that information. And then we saw a high rate of gestational diabetes. And interestingly, especially in our Latino population. So, for example, I don't have the data here, but for our Latinas in this study, about 18% of them had gestational diabetes, with compared to those women, other women that were not Latinas, we had cases of gestational diabetes, but it was less. So we are doing currently analysis right now to see if there are differences on their diet, if that explains the development of gestational diabetes, at least how much it like predicts the development of gestational diabetes. Because we know diabetes during pregnancy has other factors, not only due to diet. But thank you for the question, very interesting.
Thank you. I noticed on the chart that Colombia has a high level of sugar consumption, even with the lowest ultra-processed food consumption. What could cause this, and how do you suggest this should be reduced?
Well, in this aspect, yes, exactly. In Colombia, the sugar intake, although in the first quantile, or let us say in the lowest consumption of processed foods, represent an added sugar intake of 12.4%. So clearly, this reflects that the consumption of traditional diets of traditional dishes in Colombia I know that are based on using the ingredient panela in many dishes. So in order to reduce this intake, maybe the nutrition educational interventions should be applied in the population in order to reduce the quantity of that ingredient and therefore reduce the consumption intake of the consumption of sugar in the dietary habits of the population. So maybe that would be a primary strategy. For example, in Brazil and Uruguay, they have these dietary guidelines that are based on the level of processed foods, in which highlight that processed culinary ingredients should be used in small quantities to prepare or be combined with processed or minimally processed foods. So therefore, in Colombia, maybe they should apply some time of those strategies related to the use of panela in their traditional dishes. For example, in Mexico, the consumption of saturated fats is high, even though the consumption of ultra-processed foods is low. This is because in the traditional dishes of Mexico that are called antojitos mexicanos, such as tacos, flautas, tostadas, among others, use a lot of vegetable oils to prepare those dishes. So another recommendation in this case for Mexico should be that use a small quantity of vegetable oils to prepare such type of dishes in their culinary preparations.
Great, thank you so much. How difficult is the Latino population to intervene? Because in the older people, for example, it's very difficult to change their diets and habits.
Yes, it's like I said at the beginning of the presentation, obesity, but not only obesity, but also other malnutrition diseases are complex to be tackled. So there is a really a need in that hospitals and also policies in any other Latin American countries work together in order to create the best environment for the individuals to have a better health and nutritional status. Right now, for example, Mexico is taking a fight with the food industry in order to educate the population to consume better, to choose better food options to avoid the increased prevalence of obesity and other nutrition-related chronic diseases. But also at the same time, I created nutrition and intervention and programs to help individuals with undernutrition and with deficiencies of vitamins and minerals to have a higher consumption of nutrient-rich foods in order to prevent the development of such type of behaviors or disease, better saying.
And then I will share my opinion and perspective of somebody working with immigrants, Latino immigrants here in the US, and then before living in Brazil and working with Brazilians and being Brazilian. So I think when we think about Latin America and nutrition, we cannot think of only one thing. And as I don't know if you all watched the presentation of Francie last week, but it's not us that will change, but we need to work together with patients to change, to see what is important for them. This is in a clinical setting. But when we think of obesity, that is something so complex as we presented in the first slide, we also need to think about policies to support an environment that produces a healthy diet. In Latin countries, we have the benefit of having overall a healthy traditional diet. So in Colombia, even though, for example, the consumption of added sugar is higher than Mexico, for example, that may be due to the panela or maybe due to other types of food. There is also a wide variety of fruits and vegetables that are naturally produced, and there are sources in the country. The same happens in Brazil, the same happens in Mexico, in Peru. So we are countries that have a lot of fruits and vegetables, that have a good climate where we can produce them. But we need also to promote that the population eats them and do not change for foods, for example, the ultra-processed food that are nutrient empty. So they only offer calories and they will produce more disease. So difficulties we would find in any population. But I think it's a matter of working together, working with patients, working also in the policy level to produce policies that will promote a healthy environment. And working with Latinos and Latin American countries, I think that one thing that we have very strong is unity and also action to work for the other. So I think that working together, we can always achieve more. So I think difficulty depends on how much unity and engagement you will have from your partners.
Thank you. And here's the last question. If the overweight woman has a good diet during pregnancy, this means that she is going to gain less weight during pregnancy. So this condition won't it pose any risk to the baby?
Exactly. So if women, even if they started pregnancy overweight or obese, if they have a healthy diet and also a healthy lifestyle, that will be good. That will have good results for the baby and also for them. So that's why it's a very important time in the life for both the women and the baby, because that can impact a lot their health in the future. So to develop, for example, diabetes or hypertension, but also will impact their baby. So there are several studies showing that if women gain too much weight during pregnancy, they are programming their babies to, in the future, have a higher risk to develop nutrition-related chronic diseases like diabetes, cardiovascular disease, and obesity as well. So it's very important. That's why we are doing research in this area and emphasizing so much to support these women. But if we do these interventions during pregnancy, the question is yes, they can gain the right amount and then have good outcomes for the baby.
Great. Juliana, Joaquin, thank you so much for this talk, this incredible talk. Thank you for being part of this incredible event, and we hope to see you again soon.
Thank you.
Now, please welcome Dr. Fasika Woreta with her conference titled Evaluation of the Red Eye. Dr. Woreta is an assistant professor of ophthalmology at the Wilmer Eye Institute. She specializes in corneal and external eye diseases, including complex cataracts and anterior segments reconstruction following trauma. Dr. Woreta received her Doctor of Medicine degree from the Johns Hopkins University School of Medicine and her Master of Public Health degree from the Johns Hopkins Bloomberg School of Public Health. She completed her residency in ophthalmology at the Wilmer Eye Institute and then completed a fellowship in cornea and refractive surgery at the Bascom Palmer Eye Institute at the University of Miami, and an accident and emergency and cataract fellowship at Moorfields Eye Hospital. Dr. Woreta returned to Wilmer to join the faculty as an assistant chief of service and assistant director of the Red Eye Trauma Center from 2013 to 2014. She is currently residency program director, as well as the director of the Eye Trauma Center at the Wilmer Eye Institute. Her research interests include resident education, ophthalmic trauma, and quality improvement. She is currently the vice president of the American Society of Ophthalmologic Trauma, ASOT, and the ASOT representative to the American Academy of Ophthalmology. So please welcome Dr. Woreta.
So much, Juan Pablo. Thank you for having me as part of this wonderful event. So I'm going to speak on red eye. And after completing the lecture, I want you to be able to identify the basic anatomical structures of the anterior segment of the eye, understand the basic components of a eye exam, and then really know the presenting signs and symptoms of both bread and butter, as well as serious causes of red eye. And then finally, effectively triage and manage patients presenting with red eye. So we'll have 40 minutes of this case-based lecture, and then I'll have 20 minutes for discussion. And throughout the talk, I would like you to be thinking as a non-ophthalmologist, is this a condition you can treat yourself, or is it something that needs referral? And if it does need referral, is it something that can be routinely referred? Does it require urgent referral within 1 to 2 days, or emergent referral within the same day? So to review the anatomy of the eye, this is a sagittal cross-section. So you can see here is the cornea, and that's where light first hits. It goes through this pupil aperture here, and then it is refracted a second time by the crystalline lens, focused on the retina, and then the signal goes to the brain through the optic nerve. So the cornea, again, is a optically clear structure, 550 microns in thickness. And you can see here, there's this white surrounding tissue is the sclera and episclera. And over that is a thin translucent tissue, which is the conjunctiva. And the cornea is avascular, while the conjunctiva has vessels. And you can see here, when we talk about red eye, we're really going to focus on the anterior segment of the eye. And so the space between the cornea and the iris is known as the anterior chamber. And later on in my talk, I'll discuss when you'll see different conditions in the anterior chamber, such as white blood cells. And when you look at this section when you look at the eye like this, you can see the cornea here, again, is crystal clear. You can see the hazel iris, which constricts and dilates to let light in. And again, this is the conjunctiva with the underlying episclera and sclera, which is the white part of the eye. And then a little bit of attention here to the eyelid anatomy. This is the margin here. And in the margin of the eyelid, you'll find the meibomian glands. You can't see them well in this picture, but there are 25 little orifices here, which secrete meibum to the tear film, and there are 50 on the top eyelid. And so we'll talk about different conditions that can cause red eye, both in the eyelid and the eye. So the history is very important. As in all medical specialties, you really can get 90% of the diagnosis just by taking a good history. So if a patient complains of foreign body sensation, it's usually localized to something on the cornea. Itching is usually a sign of allergy. Light sensitivity is pretty specific for inflammation in the anterior chamber, which I'll show you in one of our cases. So patients with different types of inflammation can present with severe pain. And again, we'll go over that in the case presentation. Whenever a patient presents with headache, nausea, and vomiting, you need to think of the possibility of increased intraocular pressure. Of course, when evaluating a patient with red eye, you need to know if the patient is complaining of decreased vision, which will increase the likelihood of the need for an ophthalmology consultation. And then there's some key things in the history, such as a contact lens wear, which could predispose the patient to infection, or a history of rheumatological diseases, for example, which could predispose the patient to a number of inflammatory conditions as well as dry eye. So I'm just going to briefly review the components of the eye exam. And so we check vision, Snellen visual acuity, which for us is the vital sign. And we use OD to mean the right eye and OS to indicate the left eye. So ideally, you would have a chart and measure at 20 feet or 6 meters the vision. And if a patient wears glasses or has refractive error, you want them to put their glasses on. And we refer to there's a lot of abbreviations in ophthalmology, and we refer to with correction as CC. If the patient forgot their glasses, for example, you can also do something called pinhole vision. So if you ever see the occluder with pinholes, but basically the pinhole is doing the refracting for you. So if a patient, for example, on the Snellen chart is 2200, which is poor, and pinholes to 2020, that would be reassuring that it's something refractive. And so you can see here the big E is 2200, and and 2020 would be perfect vision. So if the patient can't read even the biggest E, you can still try to quantitate what they can see. And so if they can't see the biggest E, you start to use your fingers and see if they can count your fingers. If they can't do that, then you would wave your hand in front of them and see if they can detect the motion. And if they're unable to do that, you'll see if they see light. And then if they can't see any light at all, it's very important to document and know that, as that changes the prognosis and the treatment course. So after accurately checking the vision, we then go to check the pupils. And then, as we all know, the pupillary reaction, there's a consensual reaction. So when you shine light into one eye, both pupils constrict here. And so in this case, there is an abnormality on the left side, and we call that a left afferent pupillary defect. And so again, when you shine light into the normal right side, both pupils constrict. But then when you shine it into the abnormal left side, what should happen is that the pupils remain constricted, equally constricted. But you can see here that doesn't happen. There's actually a dilation. And that's because there's a problem on that side with either the optic nerve or the retina. And then when you shine it back to the normal eye, again, both constrict. So a number of conditions lead to abnormalities in the pupil, which you'll see in my case presentation. So assessing both the size, shape, and reactivity is important. And we check extraocular movements, which can be decreased when there's some infections, as well as confrontation visual fields. Measuring intraocular pressure can be done by non-ophthalmologists in the emergency department setting. And that's most commonly done using a portable tonopen here. So you can see what that looks like. You see these disposable tips that you change with patient use or sterilize with alcohol. And basically you have to anesthetize the eye in order to use this tonopen. And then you'll get a little reading there. And then a newer device is the eye care. And that one, you don't need any anesthetic. There's a little probe that goes in here that bounces off the patient's cornea. And then it will measure a pressure. So it's nice in kids, or if the patient doesn't like eye drops. And generally, the normal range of eye pressure is between 10 to 21. So we usually check in both eyes when you get a high reading to make sure that it's not artificially high. And then you can do a lot with the pen light. So you can see a lot of the external exam just using a muscle light or a pen light. And then in the some emergency departments in the ophthalmology office, we have the slit lamp biomicroscope. And what it is a microscope and an illumination arm. And it helps you can use magnification to see the structures in detail. So it's always good to systematically go through the exam. So we start with the lids and lashes, as I showed you, conjunctiva and sclera, cornea, anterior chamber, iris, and then lens, in that order. So there are many causes of red eye, both benign and vision threatening. So again, we're going to do case-based presentations that illustrate both of these conditions. So case number one is probably one of the most common conditions we see in ophthalmology, especially as an anterior segment person. So this patient comes in with complaining of crusting of lashes and eye irritation for several months duration. So you can see here what the external exam looks like. And in this picture, you can see on the cilia, you can see a lot of collarettes. So this is what we call anterior blepharitis. So you can see, again, debris on the eyelids. In this condition, this is on the posterior lamella of the eyelid. And remember how I said there are 25 meibomian glands in the inferior eyelid. So you can see how these meibomian glands are frothy and thick with oil. And so that is called posterior blepharitis or meibomian gland dysfunction. So they're both types of blepharitis. This one we call anterior, this one posterior. And the treatment is slightly different. So for this type of blepharitis, it can often be associated with like a staphylococcal antigens and things. So we treat this usually with baby shampoo or lid scrubs to clean the eyelashes, basically. And for posterior blepharitis or meibomian gland dysfunction, you generally treat that with warm compresses, which release the insippisated meibomian glands. So, and then sometimes when the meibomian gland gets blocked, you can get what this patient is presenting with here. So they're presenting with acute tenderness of the eyelid for 3 days. And so this is what we call a hordeolum or stye. And what that is basically one of those meibomian glands got clogged. And then so you can see here in the pathology slide, this is where the lipid is. And then there's this lipogranulomatous inflammation. So it is focally tender. And normally you don't have to treat with antibiotics unless there's an associated preseptal cellulitis, which can happen. But warm compresses frequently can help to relieve the obstruction. And then the next case is a patient who wakes up with a bright red eye. Pretty frightening for the patient, comes in to see you because of it. Vision is normal, everything's normal, pressure, pupils, and then you can see what this looks like here. So this is a classic kind of patient I see, because when the patient wakes up, it looks pretty frightening, but it is just a subconjunctival hemorrhage. So that's blood in the subconjunctival space. It doesn't affect the vision. It's completely benign. It can happen if a patient is coughing a lot, sneezing, any kind of Valsalva maneuver. And it can also happen if a patient is on anticoagulation. We do not stop the anticoagulation for subconjunctival hemorrhage because it's a benign condition. So you just reassure the patient that it looks a lot worse than it is. Okay, so the next patient is a classic presentation that you might see often in the wintertime. A patient comes in with tearing, redness. It started in one eye and then went to the next eye. And the patient also has a history of a recent cold. And the vision is, the patient doesn't complain of decreased vision, so it's 20/30. And on exam, you can see diffuse redness of the conjunctiva. Sometimes you can even see a little bit of subconjunctival hemorrhage. Again, it involves both eyes. And you can see the cornea is perfectly clear. The anterior chamber is perfectly quiet. And there's just diffuse redness. And then you can see here, when you pull down the lower eyelid to examine, you can see these large follicles, which are sort of mound-shaped, clear. And so this is pretty specific for viral conjunctivitis, which is most commonly due to adenovirus. And in addition to it being bilateral, you can often feel a pre-auricular lymph node here that's tender. So if you feel that you had your diagnosis, the patient may endorse a sick contact, somebody in the family with red eyes recently as well, like a child. We find that topical antibiotics are overprescribed in viral conjunctivitis. So, just like the common cold, you don't need to treat it with antibiotics generally. And this is the most common type of conjunctivitis there is. It's more common than bacterial conjunctivitis. So, unless the patient is complaining of a thick discharge, I generally don't just prescribe artificial tears and go over the hygiene since it's highly contagious. They can use cool compresses for the irritation and frequent hand washing. The next case is a young male who presents with a history of asthma and hay fever, who presents with redness and severe itching of both eyes, and this happens every spring. So I mentioned in the beginning, itching is often a sign of allergy. So in these patients, you want to flip the eyelid. So you can see we flip the top eyelid here, and you can see these cobblestone-like bumps under the eyelid. So remember when I showed you the follicle, it didn't have a vascular core. So the way to distinguish the follicle from the papillae is the papillae have a vascular core. And you see this, again, cobblestone appearance. So this patient, again, the itching and the seasonal component gave you clues. And often these patients do have asthma, hay fever, and eczema. And you treat it with artificial tears in addition to topical eye drops such as mast cell stabilizers and topical antihistamine eye drops. In very severe cases, you may have to do short courses of topical steroids. But you have to remember that topical steroids do have side effects, which include cataract and glaucoma. So you can imagine if young patients are prescribed topical steroids repeatedly over the course of their life, they may develop early cataract or even glaucoma, even worse. So, in some countries, the use of topical steroids is you can buy it over the counter, so it's not regulated. So that's something to keep in mind. And the next case is a pretty bread and butter poke in the eye with a fingernail. So I didn't mention the 5 layers of the cornea, but the first layer is called the epithelium, and it's very innervated. So any kind of scratch is quite painful. So the patient comes in, the vision is down because you can see this abrasion involves the central cornea. They're in severe pain. They can't open their eye. And again, in this example, you can see the first layer of the cornea has been scratched off. And the way to visualize it, besides just looking at the slit lamp and seeing the absence of the cornea, you can use a fluorescein dye. So basically, you can use fluorescein mixed with an anesthetic, or you can use an anesthetic drop with a strip of fluorescein. But basically, when you put the fluorescein in the eye, the denuded epithelium will uptake the fluorescein and it'll light up. And you can visualize it with either any kind of blue light or a Woods lamp in the emergency room. And so this is a picture. This is not a slit lamp, but an external photo. So again, you don't need a slit lamp to diagnose this, but you can see how the missing epithelium is lighting up here. When you put anesthetic in the patient's eye, they all of a sudden can talk to you and they're comfortable, and you can examine them until it wears off. One thing that it's important to remember, the patients will often ask you, can they take home the anesthetic? And the answer is no, because we know that the anesthetic will delay the healing. It can also lead to corneal melting. So I essentially never prescribe topical anesthetic for corneal abrasions. And you want to treat the patient with some ointment, because that does help the eye feel better. Usually a topical antibiotic ointment to prevent any infection, since the first barrier of the cornea is gone. 4 times a day will help. If the patient is in severe pain, you can place a contact lens for comfort, or you can patch the eye overnight because it's really the blinking of the eyelid over the raw surface that causes the pain. You want to beware if there are any risk factors for infection. So we'll talk about contact lens wear, but that's a big risk factor. And also any kind of like vegetable matter trauma. Patients are more predisposed to fungal infections. So you definitely don't want to patch these patients, and you want to sometimes think about covering them with, in addition to an antibiotic ointment, an antibiotic drop. If you see a patient that comes in with this classic pattern of vertical stria, with this abrasion in a vertical pattern, you need to flip the eyelid, because, and I've seen this several times, where you flip the eyelid and you'll find like a small, the culprit under the eyelid. And the reason it's vertical is because every time they blink, it's scraping the eyelid. So that's a pretty specific pattern. Okay, so I mentioned you have to be aware of the contact lens wear. So this is something where I've seen too many times in the emergency room setting, where the patient has a history of contact lens wear. They present with a red eye, and they're sort of treated with a little bit of antibiotic, but they come in and it's much worse. So in this case, you can see what the cornea looks like. First of all, the vision is very decreased, so it's 20/100. And then you can see here that before you even put any fluorescein dye in the eye, you can see that there's a white opacity here. And that is a corneal ulcer. So in the case of the abrasion, do you remember when I showed it to you, it was clear until you put the dye in, and then you could see it light up. But in this case, again, even with a pen light, you could see this white opacity. And when you put the dye in, it will also light up. But the difference is that there was an infiltrate before. And so this is an emergency. And it can really progress rapidly in just a few hours. So you want to refer them or begin treatment right away. And so how I would treat this is culture the cornea. And then, so you can see this is a culture media. We usually do various media, blood agar, chocolate agar, saburad. And then right after you finish the culture, you'll begin frequent antibiotics. And we use fortified antibiotics, which are specially compounded for the eye, like fortified vancomycin and tobramycin or ceftazidime. And you use the drops hourly throughout the night in order to treat this. And this is actually a patient I treated in the emergency room and so this is why I said you want to treat it right away, because just like Pseudomonas can cause bad infections in other organs, it causes really bad infections in the eye. So you can see how this progressed really rapidly and basically went to involve the entire cornea. And this is 9 times out of 10 in the contact lens wearer, the culprit is Pseudomonas. So again, it's something that you want to be aware of. And the reason why contact lens wearers are predisposed to Pseudomonas is because normally Pseudomonas is not one of the organisms that can penetrate an intact corneal epithelium. But with the contact lens, there's little microabrasions in the eye. So basically, your epithelium is not 100% intact. So that's why that's why we see it in contact lens wearers. And then just so you know that other organisms that penetrate intact corneal epithelium, so they don't need that breakdown and barrier, include Corynebacterium, Haemophilus, Neisseria species, and the Neisseria species generally present as classically as like a hyperpurulent conjunctivitis. So if you see that in a baby, for example, you should be culturing and treating right away systemically. And then there's also more rare causes such as Shigella or Listeria. But normally the epithelium is with tight junctions and you can't penetrate. So the next is a 22-year-old female who presents with redness and foreign body sensation, and she does have a history of cold sores. And this is the classic dendrite of herpes simplex. So you can see it's beautifully depicted here. And basically, HSV can have various ocular manifestations. So primary HSV can present as a blepharoconjunctivitis, and then secondary can present in a variety of ways. So I showed you the dendrite. It can also really affect any layer of the cornea. So the first layer is the epithelium, and then the middle layer is the stroma. So it can cause inflammation there. And then the inner layer is the endothelium, and it can cause an endotheliitis. It can also cause uveitis or inflammation in the anterior chamber. And then rarely it can go in the back of the eye and cause something called an acute retinal necrosis, which can be blinding and needs to be treated right away. So, a lot of presentations of a lot of manifestations. The next case is back to a benign case. So this patient presents, and it typically, classically can present in patients who have a history of a lot of sun exposure. And the patient presents with irritation, for a couple months, and sudden redness. So this is the fibrovascular wing-shaped structure here that is called a pterygium. And the reason I said it presents with in patients with a lot of sun exposure is because the pathogenesis is when you look under the microscope, there's elastotic degeneration due to the sun exposure. And basically this fibrovascular tissue then grows over the cornea, and it can become inflamed and get irritated. And so it's a totally benign condition, but it can be symptomatic just from the irritation. So normally you can treat it with maybe a short course of topical steroids, artificial tears, and then if it bothers the patient and it's large like this, you can actually surgically remove it. So we do a lot of those, but it's a benign condition. So the next case is a patient, a young male with a history of lower back pain, worse in the morning, who presents with 2 weeks of redness and light sensitivity in the eye. And I mentioned that light sensitivity is usually, what we call photophobia, is usually a hallmark of anterior chamber inflammation or uveitis. So that should sort of ring bells for you in the history. The vision is a little bit decreased, 20/40. The pupil is constricted. And so you can see what this looks like here. So you can see again, when there's inflammation in the anterior chamber, there tends to be spasm of the ciliary muscle. So that's why you get a constricted pupil, as seen here. And this patient has what we call a hypopion. So when there's so much inflammation in the anterior chamber that you get a layering of the white blood cells, that's called a hypopion. So whenever you see this, you should be calling ophthalmology, because it's usually never a good thing. It could be a sign of, again, anterior chamber inflammation or infection. So you won't have this view with the slit lamp. sorry, you won't have this view with the pen light, but with the slit lamp, you can focus the beam so that you're looking in between the two lights, and you can see little particles in here, and those are the cells. And as I said, when the cells become so much that they layer, that's what we call a hypopia. So this patient has acute anterior uveitis. The way we treat that is topical steroids frequently, every hour, for the first week. We also treat with a cycloplegic, which paralyzes the ciliary muscle to help with the pain. And usually patients with HLA-B27 classically present with the recurrent uveitis, and that's why in the history I put that the patient had lower back pain, so it could be like ankylosing spondylitis. So you'll check HLA-B27 as part of the workup, in addition to ruling out syphilis and other causes of anterior uveitis. The next patient is a 50-year-old female with the red eye for the past 2 weeks, and this patient describes severe 9 out of 10 pain, like a pounding behind the eye or a deep boring pain. So on exam, the vision is normal. All the pressure, pupils are all normal, and you can see what the eye looks like here. It's very injected. And then if you put a vasoconstrictor like phenylephrine on the eye, if it's superficial redness, then you would expect it all to blanch. And you can see in this patient, nothing really happened. And that's because this patient has scleritis. So as I mentioned in the slides of the anatomy, you have the episclera and then the sclera underneath. So the inflammation here is deep, so that the 10% phenylephrine, again, does not constrict the vessels. And so that's how you distinguish scleritis from episcleritis. So if this patient had episcleritis, number one, they usually don't describe a severe pain. It's normally a little bit of an irritation. And then if you put phenylephrine in the eye with episcleritis, all the vessels will constrict. And it's important to distinguish because the treatment is different and the underlying workup is also different. So scleritis is associated with underlying rheumatological diseases in 50% of the time. So anytime I'm making this diagnosis, I'm referring the patient for a workup. Whereas with episcleritis, it's a benign condition, so you're not really doing any kind of workup. And the treatment for scleritis is oral non-steroidal anti-inflammatory agents, and in severe cases, even oral prednisone. Whereas for episcleritis, it's usually limited, so you just do artificial tears and maybe a light topical steroid, but not oral anti-inflammatory agents. And so there's a number of systemic diseases associated with scleritis, like rheumatoid arthritis, lupus, relapsing polychondritis, polyarteritis nodosa, and there's an infectious workup that we do as well. And there's herpes again, which, like I said, can cause a lot of things in the eye. So zoster can cause a scleritis. Okay, the next case is very important because you don't want to miss this. It's a 65-year-old Asian female who notes pain in the right eye, very severe pain while watching TV in the dark, and then presents with decreased vision, vomiting, and also seeing halos around lights. So this is a pretty classic presentation. When the patient, the vision is severely decreased, so it's count fingers, so they can't read anything on the chart and only can count your fingers. The pupil is dilated and fixed and non-reactive. And when you touch the eye, it's pretty firm. And when you check the pressure with the tonopen or the eye care that I showed you, it's 55, so sky high compared to, let's say, 19 in the other eye. So this is a picture of what the cornea could look like. So it's a steamy cornea, so there's corneal edema. You can also see, again, the pupil is fixed and dilated, so it's mid-dilated classically. So it's important to recognize this condition because I can't tell you how many times I've been called, and the patient has gotten a CT scan of the brain, even a CT angiogram, thinking that this is some kind of aneurysm because of the pupil. But, a third nerve palsy causing an aneurysm won't present with the cloudy cornea and a red hot eye like this. And the pressure certainly won't be 55. So it's important to realize before you pursue neurological workup that that the pressure needs to be checked. And so this patient has acute angle closure glaucoma, in the history, the reason what happens is in the dark, the iris dilates, and or if a patient takes like cold medicines that cause dilation of the pupil, what happens is the iris basically blocks the outflow of the aqueous humor, which is the fluid made inside the eye. So there's no way for it to exit, and then the pressure shoots way up. And so you have to do a laser to relieve that block. So as soon as you make this diagnosis, you're calling ophthalmology because if the pressure is 55, that can lead to permanent damage and visual deficits. We treat with eye drops to lower the pressure in hopes to get a clearer cornea, and then you can do a laser peripheral iridotomy to create an outflow mechanism. And again, the patients are in severe pain, so they're usually quite uncomfortable. You barely can examine them. Again, nausea, vomiting. So, you know, anytime you see those signs, you should be thinking of this diagnosis and checking a pressure. The next case is a 15-year-old female with recent sinusitis who presents with redness in the right eye for 24 hours, and the eye is painful. Vision is decreased to 2100. Importantly, there is a relative afferent pupillary defect. So this is what the patient looks like. So the cornea and the anterior chamber look good, but this is inflammation around the eye. So you can see here, when you ask the patient to look to the right, they cannot. So that's a bad sign. And again, the afferent pupillary defect is a bad sign as well, because that's usually a sign of a condition of the optic nerve. Again, they can't move the eye past the midline. And so this patient has orbital cellulitis, which is a very serious condition that requires hospitalization. So just to briefly review the anatomy, so this is the eye here, this is the optic nerve, and this is the orbital septum. So you want to distinguish a preseptal cellulitis versus an orbital cellulitis. So in a preseptal cellulitis, there's inflammation anterior to the septum. So while the eyelid is swollen and tender, and for example, that can happen with the stye that I showed you that becomes infected, you can get some inflammation, but the vision is normal, the pupil is normal, extraocular movements are normal. So if there's sinusitis, which is the most common source of the orbital cellulitis, because the sinuses are adjacent to the orbit, and you get infection back here, you can see there's the optic nerve back here. So when there's an orbital cellulitis, the way to distinguish it is limitation with eye movement. They can't move their eye all around. The eye can also bulge, or you can get proptosis. The vision will be affected. And because this optic nerve is here, you can get pupillary abnormalities. So you want to be able to distinguish the two, and a CAT scan can also do that, but you should be able to do it on physical exam as well. And as I mentioned, these patients go to the emergency department and they get intravenous antibiotics. You can get the development of a subperiosteal abscess, so it's monitored very closely. Okay, so the next case is something that we get consulted for, not infrequently. So if a patient has bacteremia and we get called for a red eye, you have to worry about an infection that's seeded into the eye. So you can see that this patient, because they're hospitalized in the ICU, can't check vision, but you can see there is a relative afferent pupillary defect. And there is remember the hypopyon that I said, which is the layering of white blood cells. So again, remember, anytime you see that, you're calling ophthalmology. And then this patient with the history of bacteremia with the hypopyon, you have to assume there's endophthalmitis. So endophthalmitis is when there's an infection that involves all the layers. So it involves not only the anterior chamber, but the vitreous humor behind the anterior chamber. So it's vision threatening. And the way we treat it is, in addition to treating the bacteremia, we also can inject local antibiotics into the eye. So that's why this is an emergent consultation, and it can blind the eye quickly. So one way to get an endophthalmitis is with bacteremia and seeding, as I discussed. But anytime a patient has a history of any intraocular surgery, trauma, or any kind of injection, intravitreal injection, which we give now a lot of, nowadays for the treatment of, let's say, age-related macular degeneration, or even diabetic retinopathy nowadays, if they have a history of any intraocular procedure and they present with this, there could be an endophthalmitis, and you really need to call the ophthalmologist right away. This is the kind of thing that we treat in the middle of the night. All right, so now we're shifting gears to trauma. So the last few cases have to do with trauma. So this is a 32-year-old who's working in construction and something flies into the eye. And so they come in with irritation, the eye's red. And you can see here, right on the cornea, you can see a localized metallic foreign body. So it hasn't penetrated the eye, which is good. It's localized in the cornea, so it's relatively easy to treat. Basically, what you would do is take a 30-gauge needle and remove it, or you can take what we call a corneal burr and remove it. And the patient usually gets instant relief once the metal is gone. There'll be a small epithelial defect after you remove that, so you can treat with antibiotic ointment. This is a patient, a 12-year-old, hit in the eye while playing paintball. The vision is down and the pressure is up at 45 compared to 16 in the other eye. Because the pressure is high, the patient presents with headache, nausea, and vomiting, like I discussed. And this is not a hypopion because it's not the white blood cells, but this is the red blood cells layering, and that is called a hyphema, and that's from trauma. So this patient has a traumatic hyphema. Again, there was so much blood in the anterior chamber that it layered down and settled and causing the hyphema. So that usually is indicative of a significant trauma. And patients of the right descent, which would be sort of African descent or Mediterranean, you need to check a sickle cell trait. We know that patients with sickle cell trait, so even if they don't know they have the disease but are just carriers, they need to be treated differently because they don't tolerate high pressures, and they tend to have higher pressures than patients without the trait. But if the patient doesn't have the sickle cell trait, then you would just treat with topical steroids, cycloplegics for comfort. You want to try to avoid non-steroidal anti-inflammatories to induce further bleeding, and you have them sleep upright so that the blood can settle down and so it won't stain the cornea. So even in patients without sickle cell trait, you can have high pressure. So we usually follow these patients closely for 5 days, just to make sure that they don't have an intraocular pressure spike. And most of the time it can resolve on its own. Sometimes the pressure will be high and we have to go and wash it out. And the last case is a 5-year-old who was scratched in the eye by a cat. So this is a very telling picture here, because you can see if you try to check the pupil exam, you'll see the pupil is peaked and abnormal. So this should raise red flags for this type of injury. So actually, this is an open globe injury. So an open globe injury is basically when there is a full thickness laceration in the eye wall. So it can be in the cornea or the sclera. In this case, the full thickness laceration is in the cornea here. And that's why the iris is peaked, because the iris is literally being drawn out through the full thickness laceration. And so basically, once you see this in a child, you want to stop examining them. You want to avoid them getting upset or any increases in intraocular pressure, shield the eye. You want to make sure they're not vomiting, that they have good pain control. And then this is a surgical emergency. So we would take them to the operating room and put some stitches here and reposit the iris and give them antibiotics to prevent infection. So a peaked pupil is a sign of an open globe injury. The pressure in these cases can be low, normal or low, because there's been leakage of fluid from outside the eye. And so basically, just in conclusion, there are multiple causes of red eye, ranging from benign, as seen in green here, to more serious in yellow, which require referral within 1 to 2 days. And then finally, the urgent ones like the corneal ulcer, angle closure, endophthalmitis, orbital cellulitis, or the trauma like I just showed you, that requires sort of same-day urgent referral. So thank you very much. I think we'll have time for questions, and feel free to email me as well if you have any questions.
Well, doctor, thank you so much. Our team is selecting some questions. So I want to thank you for your talk, first of all.
Thank you. Thank you for having me.
So here's the first question. Have the critical eye illness increased with the pandemic due to the computer use?
So this question is about computer use and critical eye illnesses. So basically, there's a lot of media regarding sort of screen time. The biggest side effect from using the computer a lot is patients forget to blink. So if you look at your screen and you don't blink, you can get dry eye. There's a lot of, so I think that's the main thing, to make sure that you take breaks and you blink, use artificial tears if you have dry eyes. But other than that, the screen time, I don't think there's been any hard evidence in terms of the damage to the eyes from the screen time.
Thank you. Okay, so I think this is the only question we have. We have also some messages from Mustafa saying thank you, amazing presentation.
Thank you.
Juan Andres, outstanding.
Thank you very much. And if anyone wants to ask anything related to ophthalmology in general, like not only the red eye, I'm happy to answer in terms of if there's anything about the retina, anything, general ophthalmology.
Here we have another question. In the open globe, will the person's visions be affected to the point of causing blindness?
Great question. So, okay, so there's different types. So when you have an open globe injury, there's actually different types of classification. So you can have a penetrating injury, like I showed you, and that's when there's usually a sharp object. And those tend to have a better prognosis. You can also have a rupture. And the rupture basically happens when there's like a high velocity object that hits the eye. Let's say like a ball coming at a high speed, and that actually can blow out the eye wall and cause a rupture. And it usually ruptures in the point of the eye wall weakness, which can be under the muscles or the nimbus, which is adjacent to the cornea, or at the optic nerve. So normally the rupture has worse prognosis than the penetrating injury, just because it was such a severe injury that it literally blew out the eye wall. And certainly certainly open globe injuries can lead to blindness. Most of the time it's not no light perception, so they can see something, but we've certainly seen a lot of cases where, there's residual cornea damage. Sometimes it can damage the retina, or they need cataract surgery and things like that. So I think preventing eye injuries is like when you're playing sports, to wear the protective equipment. For kids, making sure they're supervised and not playing with sharp instruments. It's very important because yes, it can cause legal blindness. Some of the times it's lucky, like the injury I showed you, and it's small and localized, and you can fix it with a good outcome. But we do see a lot of devastating injuries. Assault, sports injuries, sharp instruments, like if you're working at home, so you make sure to wear eye protection when possible.
Thank you. So here's the next. Thanks a lot. Please explain us how is a normal exam in a newborn, and does conjunctivitis in the newborn can be treated with gentamicin?
Okay, great. So basically, when a baby is born, we don't do routine eye exams when they're born unless they're premature. And if they're premature past a certain age, then you're at risk for something called retinopathy of prematurity. So then the ophthalmologist will do. There's very strict guidelines for retinopathy of prematurity, when to do it to make sure that the retina, basically when you have retinopathy of prematurity, you can get abnormal blood vessels that can cause problems. So the ophthalmologist sometimes has to laser. So that's one thing. Now for the normal newborn, whenever a newborn is born, when a baby is born, they used to put, at least in the US, they used to put silver nitrate drops in the eye. And they found that those silver nitrate drops actually caused a chemical conjunctivitis. And so now we don't use that. We use erythromycin ointment. And I don't know what they use in other places outside the US, but in the US, when a baby's born, everybody gets a strip of erythromycin ointment to prevent infection. That's less irritating than the silver nitrate. Now, so if a baby presents with conjunctivitis, neonatal conjunctivitis in the first month of life, you basically, so some of the reasons, one of the reasons could be the chemical one, like I told you. Another reason could be chlamydia infection. So those babies present usually with like a watery discharge, and you have to treat that systemically. And then you can also get the feared Neisseria gonococcal infection, and those babies present with a hyperpurulent discharge. So I would say for neonatal conjunctivitis, you would want to consult the ophthalmologist so that we can do a culture and treat appropriately. And the Neisseria gonorrhea is very serious in the newborn. It can cause corneal perforation and blindness. So you really need to treat aggressively. So we treat with frequent topical eye drops, which can include gentamicin, and then also lavage and very close exams to make sure that the cornea doesn't perforate. And then I think taking the culture and making the diagnosis is important. But so any newborn presenting in the first month of life with discharge should be examined by an ophthalmologist. And again, with the watery discharge, you have to worry about chlamydia as well. But the reason we do the erythromycin prophylaxis is to prophylax against any, any infections through the birth canal.
In the clinical practice, what cases have you treated most?
Well, so my specialty is cornea and anterior segment. So I do treat a lot of corneal ulcers. So that's why I gave my piece about the contact lens, because we do see a lot of contact lens related ulcers. Some contact lenses, they advertise you can sleep in them for 1 month, and we never recommend that. You should always take them out every night. And then, be very careful about the contact lens hygiene. And the other thing is, again, I'm biased because I think I'm the director of the eye trauma center. So we do see a lot of eye trauma. So, and that's very unfortunate because it often happens in, young adults, maybe working, maybe construction is their job. And so when they have a serious eye injury from not wearing eye protection, for example, that can really affect their livelihood. So we see a lot of eye trauma. Other than that, in my day-to-day practice, I mentioned that we see a lot of blepharitis and dry eyes. As a cornea specialist, I think a lot of us see that. Age-related cataracts is another big part of my practice because cataracts are so common over the age of 60. So those would be sort of the main things that I see.
In the red eye infection caused by herpes, what is the most recommended treatment?
Yeah, so that's a good question. So there was a big clinical trial called HEADS, herpetic eye disease study, which looked at this. And the bottom line is there are different types, depending on remember how I said it can affect there's different, it can affect the stroma, for example, the epithelium, it can cause a uveitis. So the treatment differs based on what the level is. But basically you can treat with oral antiviral. So that would be either acyclovir or Valtrex. And in addition to that, you can treat, the treatment depends on the layer. So like in that patient I showed you with the dendrite, you could treat that with a topical antiviral, such as topical ganciclovir, or if it involves, if it causes a stromal keratitis, which is an inflammation deeper in the cornea, or a uveitis, inflammation inside the eye, sometimes you do have to treat with a topical steroid. And the thing is, just like, so it basically reactivates the virus. So a lot of times patients will have like recurrent inflammation because of this. So some patients you will keep on a prophylactic dose of acyclovir, and you have to treat them with some low level of topical steroid in order to keep the inflammation at bay. And then the one condition I mentioned, which is acute retinal necrosis, where that can be caused by herpes simplex. It basically causes a really bad retinitis, which it's like in the retina. It can basically eat away at the retina, and that one you actually have to treat with an injection in the eye. So, but just to answer your question, it's, you know, oral antiviral therapy is really the mainstay, and there are topical antivirals as well. And then a lot of times they need anti-inflammatory medications because it's like the body mounting an immune response that sort of causes some of the damage in some cases. But there was a big clinical trial which sort of specifies what we should do in terms of oral therapy, anti-inflammatory, and so forth.
In the clinical practice, which is the better exam and why?
I'm not sure I understand that question in terms of the, you mean, I'm not sure if I understand what we mean by better exam in terms of the way to examine the eye, or not sure if you can clarify that.
I think it's probably the evaluation of the eye.
The evaluation, yeah. So, I mean, really, I mean, the slit lamp is the best because you can have the patient sit there and you can use different magnification and look inside. But, you know, you can see a lot with just a pen light as well. So, like, I can diagnose a corneal ulcer with just looking with a pen light. So I would say if you don't have a slit lamp, you should get, you know, a good pen light or muscle light, and you should be able to see the external, like the conjunctiva, the cornea, and so forth. And then, you know, with ophthalmologists, we come and look at the back of the eye by dilating it, and we use special lenses, so we really get a good look at the entire retina. You know, that's beyond the scope of an internist because the eyes are not dilated, and also the direct ophthalmoscope only gives you an image of the optic nerve. But so if you need, that's why it's important to know the indications for calling the ophthalmologist, because we certainly can get a more specialized exam with our equipment. So it's important to know when to call, and also the timing of, you know, of when to call. So if there's a significant history of trauma, you don't want to miss like the open globe, for example, and you don't want to miss a corneal ulcer, for example.
Excellent presentation. In the case of traumatic injury due to vegetations, with antibiotic will be indicated.
Thank you. Yeah, it's a good question. So the vegetable matter. So I actually, when I did my fellowship in Miami, Florida, I saw a lot more fungal infections because of the climate. So you have to, whenever I hear like tree branch or vegetable matter, you have to worry about the patients at risk for fungal infection. So if you treat them with, let's say they have like a scratch on the cornea, you can treat them with topical antibiotics, antibacterial medication, but you need to follow them closely for the development of any signs of fungal keratitis. And so normally if you can see, you'll see an infiltrate developing, and if it's suspicious, then I'll start antifungals in addition to the antibacterial medication. And also for fungal infections, they don't like, fungus likes steroids. It helps them grow. So I avoid steroids in these patients.
And here's the last question. Due to COVID-19, do you recommend wearing contact lenses? Do contact lenses increase the risk of airborne transmission? Thanks.
Yeah, that's a good question. Yeah, there was some debate initially about like glasses versus contact lenses. I mean, the thing is, I think you know, so we all have at work, we all have to wear like a face shield and eye protection. So I think most of us are using eye protection. So I think glasses is preferred in the case of COVID-19. And it also, again, the glasses provide like an extra shield. So, but I don't know if there are any studies for the contact lenses, but I know most of my ophthalmologist colleagues who wear glasses are reverting to glasses during this time period. I think the main thing is, that you have to be careful with transmission in terms of touching your face, touching your eyes, and things like that. So.
Great, doctor. So thank you. That was the last question. Thank you for being part of this project. Thank you for your time, and we hope to see you again very soon.
Thank you so much. Thank you, everybody, for the questions. I appreciate it. Thank you. Good night.
Good night.